Hello.
Hello, Dr. Filippiadis. Hi.
Should I say good afternoon? What's the time over there? Evening.
Yeah. It's 8 p.m. here in China.
Okay.
Okay, yeah. We have Dr. Zhou and Dr. Chen. So, hello, Dr. Zhou, Dr. Chen, if you would like to say hi. Yeah.
Hello, good evening.
Hello, good afternoon.
Hello.
Yeah, we have a couple more minutes to start our webinar. So as we planned today, we have 3 main topics, and there will be a 30 minutes Q&A. I'm sure there will be some questions in the chat box, but in case not many questions, so we hope that you can communicate with each other if that's okay.
Great.
Okay, perfect.
Do you want me to share my screen?
Yeah, you can do that. Okay. Okay, so it's 8 p.m. here in China, so I think we should get started.
Great.
Okay. So good evening, everyone. Welcome to CCMA webinar on microwave ablation. And I'm Dana from Eco Microwave Company. On behalf of CCMA and Eco Company, I'd like to thank you all for joining us today for this program. And now please allow me to introduce our speakers. We have Dr. Dimitris Filippiadis, Associate Professor at University General Hospital at Deakin Medical School, National and Capodistrian University of Athens. Welcome, Dr. Filippiadis.
Thank you very much. It's a great pleasure to be here.
Good to have you. Okay.
Thank you. So starting, are we going to introduce the other speakers as well?
Yeah, let me introduce and we will get into the main topic.
Great.
Okay. And we have Dr. Yang-tian Chen, Associate Professor, Master Supervisor, Head of the Cardiothoracic Surgery and Interventional Radiology at Fujian Provincial People's Hospital. Welcome to join us, Dr. Chen.
Hello, everyone.
Hi, thank you very much for joining. And next I will introduce Dr. Wen-bin Zhou, Associate Professor, Master Supervisor at Jiangsu Province Hospital, Jiangsu Women and Children Health Hospital. Welcome, Dr. Zhou.
Hello, everyone.
Hi, thank you very much. It's good to have you. Before we get to the main topics, I'd like to remind our audience one more time that today there will be 3 main topics and a Q&A session after the lectures. So any questions can be left into the chat box so that we will get into them in the Q&A session. So that's it. And without further ado, let's start the first topic, ablation techniques for tricky liver cases. Dr. Filippiadis, welcome.
Thank you. Thank you very much. Many thanks to CCMA and Eco Company for the invitation and for hosting this great webinar. Greetings for Athens. In the next 20 minutes or so, I will try to run a review and present cases upon microwave ablation techniques for tricky liver cases. These are my financial disclosures. Hope everybody can see the presentation running. I have served as a consultant and advisory board member for different companies. Some of them are related to microwave ablation, and I have received support for industry research, mainly in the field of percutaneous ablation. Starting with tricky liver cases, I googled the term tricky, and the synonym for tricky cases seems to be difficult, complicated, complex, and even subtle cases. If we want to translate that in clinical practice, in liver ablation, we should speak about challenging tumor locations, non-visible lesions, lesions of large size, and last but not least, new frontiers in histology. So during the next 20-25 minutes, I will try to focus on a wide variety of liver lesions, including primary, like hepatocellular carcinoma and intrahepatic cholangiocarcinoma, and of course, liver metastasis. It is well known that the anatomical location of the hepatic tumor has been previously reported as a significant contributing factor for local recurrence following percutaneous ablation. Actually, challenging tumor locations in the liver include lesions located in the hepatic dome, areas close to the liver hilum or to the heart, lesions located subcapsularly, exophytic tumors, and tumors subducting the diaphragm. In these cases, most commonly, the creation of a limited ablation volume is performed when we do require a more aggressive approach. A conservative ablation strategy resulting in other treatment is mainly attributed to the attempt to avoid complications from either direct penetrating or from more commonly due to indirect thermal trauma. However, we should all remember that the goal for a percutaneous ablation with curative intent should be an A0 ablation. That means total necrosis of the lesion with adequate safety margin. And there are three main factors of success for percutaneous ablation: margins, margins, and margins. Therefore, whatever you do, you should have adequate safety margins. And this is supported in the literature. This is a great paper published in a radiology journal in 2015 from Sloan Kettering Hospital in New York. Kostis Apokleous and colleagues evaluated 162 patients with over 203 tumors. All these lesions were colorectal cancer liver metastasis. And what they have found was that local tumor progression rate was 15% when the margins were ranging between 5 and 10 millimeters. On the other hand, when the margins were over 10 millimeters, the local tumor progression rate was decreasing down to 5%. And this difference was statistically significant. Similar in another paper from the same group, once again evaluating colorectal liver metastasis, it has been shown that margins are very important even for the biologic character of colorectal liver metastatic disease. And the authors in this paper concluded that the relative risk for local tumor progression after ablation of KRAS mutant colorectal metastasis with narrow margins was 16.8. I repeat that, 16.8 times higher than the risk in KRAS wild type when these lesions were ablated with margins over 6 millimeters. This is why more often nowadays we do perform percutaneous ablation with 2 or even 3 microwave antennas, aiming to create this large size ovoid or sometimes spherical ablation zone with a diameter over 5 centimeters. And this is what happens in the liver after a successful ablation with clear margins, after an A0 ablation. You can see the metastatic lesion located in the periphery of segment 7, the necrotic zone 6 weeks after the ablation, and a gradual reduction on the size of the zone of necrosis at 6, 12, and 48 months after the A0 ablation. So always remember, it's a necessity to perform ablation with clear margins, otherwise called A0 ablation. Starting with different locations, let's start with lesions close to the heart. This is an experiment performed for pulmonary microablation, but the result is very interesting and can be applied in the liver. The authors concluded that microwave lung ablations performed more than or equal to 5 millimeters from the heart are associated with a low risk of cardiac complication. And of course, we can apply and we can include microablation in our everyday clinical practice for paracardiac locations in the liver. This is such an example. This is a patient with synchronous colorectal cancer metastasis. There are 2 lesions, one in the hepatic dome and the other one higher in the dome on a subcapsular location right next to the pericardium. You can see the axial and the coronal reconstructions of the computed tomography scan prior to any ablation. Nowadays, for these locations, we use an electromagnetic navigation system. It makes our life really easier to approach lesions in the hepatic dome with an angulated caudal to cranial approach. This is the planning screenshot for both livers. This is the final control screenshot for both lesions. You can see on the right side of the slide the final location of the microwave antenna in both lesions. Look on the lower image how close we are to the pericardium and pay attention to the approach. When you are actually targeting towards the pericardium, the expected ablation zone will extend posteriorly to the active tip of the microwave antenna. Therefore, you diminish the chance of causing thermal damage to the pericardium. In this slide, you can see axial image during a microwave ablation session and the immediate follow-up in portal venous faces with a zone of necrosis. Interesting enough, the total duration from entrance of the patient to the CT room till the exit of the patient was only 48 minutes. We scanned the patient only 8 times, and actually 3 out of these 8 times were the triple phase scan performed for follow-up immediately after ablation. If we are speaking about specific details for duration of each phase, the planning time lasted 7 minutes, the needle insertion time was 12 minutes, the ablation itself was 10 minutes, followed by the immediate imaging follow-up scan, which lasted 3 minutes. From time to time, specifically for metastatic patients, due to the systemic therapy or due to the nature of the lesion itself, you can have invisible lesions. With the new softwares, you can perform microwave ablation. You can have your arterial and portal venous scan, mark the lesion whenever it's visible. In these cases, you can see this purple round marker with a cross inside. You perform your ablation, insert the microwave antenna, do the ablation, and you can roughly evaluate and be happy with your safety margins once again. In the literature, there are many studies suggesting application of microwave ablation in difficult location. For example, this 2021 study evaluating microwave ablation in perivascular and subdiaphragmatic hepatocellular carcinoma lesions. The authors included 80 patients with over 130 HCC tumors. Out of these 80 patients, 43 lesions were HCCs located really close to a vessel, less than 5 millimeters from a vessel groups of patients. And this is very interesting, this is very important, because it actually highlights the efficacy and the safety of percutaneous microwave ablation for this difficult and challenging location. If you want to compare radiofrequency with microwave ablation, this is an excellent study published in JVIR 2017, once again by Kostas Sophocleous, and the authors actually concluded that both thermal ablation techniques are good enough concerning survival rates when you have safety margins. However, microwave ablation excelled radiofrequency and provided superior results when the lesions were located close to a vessel. Therefore, this is another evidence that microwave ablation for lesions, hepatic lesions close to vessels, is an excellent tool governed by high rates of safety and efficacy. That's an example. It's a fairly large lesion, HCC lesion, located perivascularly in the junction of the hepatic veins. We have inserted one microwave antenna, performing 2 or 3 repositions, and you can see the final result with a significantly large necrotic zone without evidence of tumor remnant after microablation in a very challenging perivascular location. Nowadays, in the literature, we are trying to define criteria for resection and ablation, starting from colorectal liver metastatic disease. This is the division suggested by the collision trial from Amsterdam. And although in type 3, these are really centrally located lesions close to the hepatic hilum, the authors are suggesting non-thermal ablation on terms of IRE or SBRT. I would suggest that if you pay attention to the approach of the microwave antenna towards this lesion, if you pay attention to to the ablation session itself, you can treat lesions of small to medium size located really close to the main portal and bile ducts in the liver hilum. This is such an example from colorectal liver cancer treated once again with microwave ablation under CT guidance. What about surgical sutures? Often we do get referrals from the surgical departments for lesions which are recurrences right close to the surgical bed. This is such a patient. The patient is suffering from renal cell carcinoma, liver metastatic disease, and you can see there are actually two metastatic lesions, one located posteriorly right next to the surgical sutures, and the second one smaller, which is on a subcapsular location with an exophytic component. We started with a patient in supine position, performed microablation. If the active tip of the microwave antenna does not touch the surgical sutures, you are safe enough to perform the microwave ablation. Following, we turn the patient to prone position, perform the microwave ablation in the second smaller metastatic lesion with the exophytic component. In this slide, you can see the large ablation zone that we have achieved for the first lesion. You can see the surgical sutures right here. Always, and I will not get bored of repeating that, we are aiming for adequate large safety margins. And this is the second smaller lesion located in the subcapsular location. This is the ablation zone inside the liver. And you can see the fat necrosis surrounding the exophytic component of the lesion. This is the target sign that we really love to see anytime we have an exophytic lesion, no matter what the histology is. A very important issue is microvascular invasion. Specifically for HCC, we know that as the diameter increases over 2 centimeters, microvascular invasion is present in approximately 1/4 of the cases. And the percentage and the number of microvascular invasion is increasing with the diameter of the HCC lesion. In these cases, we need to modify our ablation technique. We can either use more microwave antennas, or we can associate ablation to another therapy, aiming to achieve reduction of recurrence rate. This is a patient with hepatocellular carcinoma. Pay attention to the significance of proper imaging prior to ablation. You can see the hepatocellular carcinoma lesion in arterial phase. You can see the vessel located close by. It's a sign of microvascular or even macrovascular, one would argue, invasion. Interesting enough and very important for the designing of your therapeutic strategy is this lesion right next to the larger one, which can be considered as a microsatellite lesion. We started with transarterial embolization. We performed conventional TACE in this patient with lipiodol. You can see the result and the presence of lipiodol inside the lesion in arterial phase immediately after the embolization, followed by microwave ablation in the same day. That is a case back from 2014. Total necrosis, follow-up at 3 and 5 years after the ablation with MRI imaging, and you can see there is no sign of tumor remnant or tumor recurrence in 5 years follow-up. This is what we want to struggle for in order to be able to compare our performance for microwave ablation with surgical approaches. Nowadays, we have different techniques in our own therapeutic armamentarium that we can combine with percutaneous microwave ablation. Forgive me if I'm biased, but I'm a microwave guy, and I strongly advocate for application of microwave in these hepatic lesions. My first microwave ablation case was back in 2008, and ever since we have shifted all our practice, especially in the liver, to microwave ablation. So, if you have 5 cc's of hepatocellular carcinoma, this is something that we are discussing a lot nowadays. You can perform balloon-occluded TACE in combination with percutaneous microwave. And this is a great approach for these large-sized lesions if you want to avoid insertion of 2 or 3 microwave antennas. You need to have an angio suite of high quality with cone beam CT. You insert your microcatheter super selectively inside the lesion. You inflate the balloon. You perform the microwave ablation with the balloon inflated, followed by the transarterial chemoembolization, and you can see that you can create a 5 to 6 centimeters in diameter zone of necrosis in the lesion with these combined approaches. What about new frontiers in histology? Intrahepatic cholangiocarcinoma is something that will come and actually is coming really hard for percutaneous management. This kind of malignancy represents 5 to 20% of all liver cancer. However, the 5-year survival rate is very poor, going down only to 5%. The resection is possible only to 1/5 of the diagnosed patients, and actually, even to the patients who are surgically resected, the recurrence rate after hepatic resection is very common and can be up to 70%. In this intracellular cholangiocarcinoma patient, there is a clear role, there is a clear space for application of microwave ablation in the therapeutic plan for intrahepatic cholangiocarcinoma. In the literature, you will find different studies that are not so many patients included. They utilize different thermal ablation techniques, all of them, however, with very high safety and efficacy rates. In my mind, specifically for intrahepatic cholangiocarcinoma, and due to the infiltrative characteristics of the lesion's boundaries, you need to have adequate margins over 1 centimeter surrounding the initial lesion. And that means that you need large ablation zones offered with a diameter over 5 centimeters. This is a great area for multi-probe microwave ablation, which will provide simultaneous ablation with different antennas in the same session. This is such a patient. She was a female 69 years old patient with a solitary recurrent intrahepatic cholangiocarcinoma located really close to the junction of the hepatic veins. During the last 4 years, patient had undergone hepatic segmentectomy in 2017, radioembolization due to tumor recurrence in 2018, wedge resection and intraoperative ablation in 2019 due to new lesions in the junction of the hepatic veins in segment 4. In 2021, patient experienced a new recurrence in the segment 4 lesion, and you can see in this axial MR sequence with fat signal suppression post-intravenous injection of gadolinium, the viable tumor in the periphery of the previous ablation zone. As you can see in this slide, we have inserted 2 microwave antennas parallel one to the other. We perform a 10 minutes ablation session simultaneously for both microwave antennas, if I recall well, at 70 watts. We reposition both antennas, perform an extra 5 minutes for each antenna, once again at 70 watts. These are images from the case that morning. You can see the 2 microwave antennas located parallel one to the other with a distance of 2 centimeters between the 2 antennas, and you can see a 7 centimeters ablation zone immediately after in the arterial facing coronal reconstruction. And these are the images from MRIs, during the first 12 months of follow-up that we are running. At 3, 6, and 12 months of follow-up, we do not have any evidence of tumor remnant or tumor recurrence. There is no evidence of viable tumor 12 months after microwave ablation for intrahepatic cholangiocarcinoma. I started my presentation speaking about margins and microwave ablation with all the technical advantages that govern this specific thermal ablation technique is a great tool for achieving adequate margins. And now you do have different softwares which can help you evaluate adequacy of your safety margins. And this is one of the recent games, one of the recent toys that I have available in my department. We quantitatively evaluate the safety margins of our ablation. We have a scale ranging from 1 to 5. 5 is the best ablation quality level, and we are trying to improve ourselves on everyday clinical approach with percutaneous microwave. As I have said in my presentation, and I promise these are the last 2 minutes, microwave is a great tool. If you compare it with radiofrequency ablation, up until now, we don't have evidence that one technique excels the other in terms of survival, but it's my personal belief that this has to do with the different characteristics, with the different biology and molecular characteristics of the disease. What we do have, however, is evidence that microwave ablation works better than radiofrequency on challenging locations. And I was kind enough not to show any of my papers upon this topic, but most interesting, we have evidence that microwave ablation is a cost-effective technique for liver lesions treated with this approach. This is a 2021 cost-effectiveness analysis of local ablation and surgery for liver metastasis of oligometastatic colorectal cancer. This analysis demonstrated that microwave and surgery offer a comparable efficacy. However, and this is the most interesting part, microwave ablation was the most cost-effective strategy in intermediate resource settings and can be considered as a cost-effective alternative to surgery in high resource settings. Similar, this is another healthcare-related cost and survival analysis published in 2022. Once again, microwave ablation was proved to be associated with decreased morbidity, decreased time spent in medical facilities and healthcare-related costs within 2 years of initial treatment, with equal overall survival when compared to surgery. These are high-level data, and they exist only for percutaneous microwave ablation in the liver. This is why, for such a superficial and peripheral lesion, which can be easily treated with a surgical resection, most probably with an atypical wedge resection, else called metastasectomy, the ideal approach is not surgical. It's percutaneous approach, percutaneous microwave ablation. You can see the antenna located in the liver, and once again, you can see the ablation zone, total tumor coverage with adequate safety margins. Closing up, tricky liver cases include characteristics such as location, size of the lesion, and don't forget histology. Percutaneous microablation performed with curative intent is a safe and efficacious technique for local tumor control, most importantly for achieving A0, ablation with clear and adequate margins. Always pay attention to the approach to the lesion. You can use in your everyday practice navigation systems and verification softwares in order to augment the quality of provided services. Many thanks for your attentions. I'm here to take up all your questions. I would like to remind all of you that tomorrow we have an international interventional oncology meeting held in Athens. This is the registration, and you can attend the meeting on a live streaming. Don't forget the largest conference on interventional oncology, the ECIO 2023, which will be held in Stockholm this year. Thank you very much.
Thank you. Thank you very much, Dr. Filippiadis. I think that was very informative, and we will be waiting for some questions in the chat box. So if you don't mind, we would like to move to the next speech. Thank you. Thank you. So next we have Dr. Chen with the topic of clinical application of microablation in lung tumor treatment. So welcome, Dr. Chen. Dr. Chen, I can't hear you.
Can you hear me?
Yes, now I can hear you.
Okay, there is something trouble with the phone.
Okay, it's okay.
Let me share my screen.
Okay, please.
Can we start?
Yes, please.
Okay. Good evening, everyone. I'm Dr. Chen from the Fujian Provincial People's Hospital. Now I'm going to be talking about some basic knowledge about clinical application of microwave ablation in non-tumor treatment. As we all know, nowadays, lung cancer has become the commonest cancer and the leading cause of cancer death in both China and the United States. By 2022, China is supposed to have about 1 million new lung cancer cases and nearly the same number of lung cancer deaths. Among them, about 60% lung cancer cannot be resected surgically due to various reasons. With the popular use of low-dose CT in routine physical examination, more and more GGO can be detected, and most of them are likely to be diagnosed finally as early-stage lung cancer. High-risk GGO are likely to be early-stage adenocarcinoma. The subtype of pulmonary adenocarcinoma include AAH, AIS-MIA, and IAC, which are the different progressive periods of pulmonary adenocarcinoma. AAH, AIS-MIA are usually called as pre-invasive lesions, which are unlikely to spread through airspace or invade directly into adjacent tissue or metastasis to other organs. Local treatment methods, including surgical resection, SBRT, and imaging-guided thermal ablation, are available methods to cure the cancer. In clinic, high-resolution CT or thin-layer CT scanning is used to find out the imaging details of pulmonary lesion and assess the possibility to be lung cancer. Consolidation tumor ratio is a parameter to assess the possible pathological progress stage. If the CTR is less than 0.25, the specificity to be diagnosed finally as pre-invasive lesion is up to 98.7%. In local treatment, such as thermal ablation might achieve a curative effect. Thermal ablation is one of the energy-based ablation techniques to treat tumors. It utilizes biological effect of heat to directly cause irreversible injury or necrosis of tumor. Radiofrequency ablation, microwave ablation, and cryoablation are commonly used to treat tumors. However, each ablation technique has its own advantages and disadvantages. Radiofrequency ablation is one of the earliest ablation techniques used for the treatment of solid tumors. Inserting radiofrequency electrodes into the tumor tissue and applying the alternating current with a frequency of 375 to 500 kHz can cause mutual friction and collision of ions with the tumor tissue, which produce thermobiological effects that increase the local temperature up to 60 to 120 degrees centigrade. When the tissue is heated at a temperature over 60 degrees centigrade, coagulative necrosis may occur. Cryoablation system for tumor necrosis also utilize argon helium gases to produce temperature gradient cycle based upon Julian-Thomson theory. The changes in the temperature gradient lead to protein denaturation and cell lysis in the target tissue. Also, tissue ischemia and necrosis caused by microembolization. During microwave ablation, a microwave electromagnetic field was produced, and the water, protein, and other polar molecules within tumor tissues vibrate at high speeds, in which result in a collision and mutual friction between the molecules. The temperature can be raised up to 60 to 150 degrees centigrade in a short time, leading to coagular necrosis of the cell. However, microwave ablation has higher convention and no heat sink effect when compared to radio frequency ablation. So microwave ablation seems to be more effective and faster than radio frequency ablation on the treating of non-tumors due to less thermal precipitation in non-tissue. When talking about how to do a microwave ablation procedure more effectively and safely, we should know quite well about the procedure platforms. We usually use CT as the commonest imaging guidance. Sometimes we also use MRI, CBCT, or bronchoscopic and electromagnetic guided as well. The indication for curative ablation on tumors including the early stage lung cancer, inability to tolerate or unwilling to undergo surgical resection or SBRT. The residual lesions on multiple pulmonary non-adenocarcinoma or pulmonary metastasis tumor also candidate for ablation. Sometimes if the lesion is in a single lung because of various reasons, imaging guided thermal ablation might be a better option than surgery or SBRT. The contradictions including severe hemorrhage tendencies, severe pulmonary fibrosis and pulmonary hypertension, infectious and radiological inflammation around the lesion, and severe organ insufficiency or poorly controlled malignant pleural effusion is not suitable for ablation. If the patient's expected survival time is less than 6 months, microwave ablation is not recommended. The procedure including 6 steps. The first one is planning, targeting, ablation, monitoring, modification, and assessment. Before ablation, we should determine the gross target region, carefully defined by the imaging including the location, size, shape, and its relationship with adjacent organs. Selecting the appropriate body position and puncture site on the body surface. Determine the puncture path from the puncture site to the deepest border of the lesion. We usually take the 3 steps protocol to do targeting. Puncture the antenna layer by layer. Step 1, outside the chest wall. Step 2, puncture into the nerve through pleural. Step 3, finally get close to the target lesion. The 3D CT reconstructed image can be applied to assess the targeting. When targeting is confirmed, we choose the appropriate ablation parameters to start ablation. Usually have to adjust the parameter according to the tumor size, shape, or location. CT scan used to monitor the application during the whole procedure to find out whether there is any off-target adjustment of the antenna, the treatment of preparing region of ablation, and any complications including hemorrhage or pneumothorax. Intra-procedural modification may simply reposition the antenna or adjust the ablation parameters based on experience or imaging findings. And a repeat large range CT scan should be carried out at the end of the procedure to assess immediate response with technical success and operative margin. Contrast-enhanced chest CT is the standard method used to evaluating technique efficiency. In order to provide an accurate outcome evaluation after operation, we should surveillance imaging change according to regular follow-up. This is a cavity on the 3 months later after microwave ablation. This is a sign for scar about 6 months after microwave ablation. This is the fibrosis sign at the end of the 6 months later. All of these are complete curative ablation site. Now we are going to present some clinical cases about microwave ablation of lung tumor. Case 1 is the old female, suffered from esophageal carcinoma undergoing radical surgical resection. During the regular follow-up period, bilateral lung nodule was noticed by regular chest CT scan, which increased in size rapidly, supposed to be pulmonary metastasis lesion. We perform microwave ablation of the two nodules in the right side in the first step. And the ablation's results seem quite good according to the CT scanning. The following ablation of lesion in the left side supposed to be carried out later, but widespread of tumor, including vertebral metastasis, was confirmed shortly after the first ablation, and the patient died in 6 months later without taking any further treatment for economic reasons. But we still find out the obvious curative ablation result by comparing the two sides CT imaging in the same follow-up point. When the right side lesion was decreasing gradually in size, the left side increased in size. Case 2 is a male, 71 years old with 20 years smoking history, suffered from the cerebral ischemic stroke 3 years ago, found out to be a new onset of acute cerebral infarction by routine preoperative examination of brain MRI, taking account of the high risk of cardiac and cerebral complications. The patient and his relatives decided to choose microwave ablation combined with a percutaneous non-biopsy at the same time. A coaxial biopsy needle was used to accomplish the biopsy task, accompanied with a curative ablation. First, we used a coaxial needle to puncture the chest wall and cut through the planning path. When the tip of the needle gets close to the anterior margin of the lesion, a microwave antenna was conducted through the needle to go inside the target lesion. And then the ablation about parameter about 40 bars for 2 minutes was carried out for pre-ablation procedure in order to coagulate the small vessels along the lesion. After the pre-ablation procedure, biopsy gun was inserted through the same needle and non-biopsy was performed. Antenna was conducted immediately again to hemostasis the possible bleeding caused by biopsy cutting with a parameter of 45 bars for 30 seconds. And then routine ablation was continued with a parameter of 50 bars for 3 minutes. Immediately scanning after ablation showed the target nodule was broken up. There is no hemorrhage on pneumothorax. The final pathological finding is micro-invasive adenocarcinoma or more invasive stage. This is the post-ablation target zone on the first post-operative day. The target lesion absorbed gradually in the regular follow-up point, and 9 scars appeared 6 months later. Case 3 is a 54-year-old man with a positive chest CT finding. There is a mixed GGO in right upper lobe, confirmed by PET CT with high risk of early-stage lung cancer. Non-biopsy was carried out, and the pathological findings indicate micro-invasive adenocarcinoma or more progressive stage. Poor lung function without any improvement after 3 weeks regular cardiopulmonary rehabilitation. Microwave ablation on target lesions in right upper lobe was performed finally. During the ablation procedure, pneumothorax was occurred due to the poor lung condition. and a drainage tube was inserted to drain the gases in the chest CT continuously to make sure the inflation of the right lung tissue. Meanwhile, the adjustment of the mitral valve ablation applicator was carried out in the same time. After the confirmation of retracting and ablation continued with 50 volts for 8 minutes. The tactic nodule was broken up almost in the CT imaging immediately after operation. Pneumothorax remains for more than 40 days after operation, and various conservative treatments was failed, including intrathoracic injection of high glucose and albumin. Finally, we do 3D reconstruction of bunkers to identify the target bunkers. Injection of glue through bronchoscope was successful to cure the bronchopulmonary fistula. During post-operative follow-up period for 1 year, the ablation lesion was stable and absorbed gradually without recurring sign. Case 4 is a 47 years old female suffer from thyroid carcinoma. Before the operation, the chest CT found out multiple GGO on bilateral lungs. Regular follow-up continues by years till the end of 2018. A little bit change about size of GGO in left side was noticed. And wedge resection on left upper lobe and lower lobe was performed. Totally, 4 lesions was resetted and proven to be adenocarcinoma in situ according to the specimen finding. 4 months later, a mitral valve operations was carried out on the 2 high-risk GGO in right side. Successful operation procedure was confirmed by the routine follow-up imaging. The nodule was absorbed gradually and finally turned to be a line scar 2 years later, which proven to be a typical curative ablation sign. About 1 year later, a residual GGO was noticed in that side, supposed to be adeno-instituted according to the detail of CT images. So a second mitral valve ablation was performed. And the final ablation findings seemed to be good according to the following up CT imaging. The lesion finally became a fibrosis on 18 months later. From all above, we see so many encouraging ablation results about mitral valve ablation on non-tumor. Effective and safe and fast. However, there are still some limitations associated with this technique. For example, the basic research is relatively insufficient, such as distribution of complex thermal fields and the effect on body immunity, which still need to be continuous explored in future. And there is still some challenge, for example, biopsy of GGO. Also, breathing during the biopsy cutting might be a great trouble for later operation. It is hard to differ where is the breathing or where is the operation zone. And also it's difficult for pathologists to do a correct diagnosis always for so small specimen. We might need more precise tools or new biomarker to get correct answer to each biopsy, especially for low stations smaller than 8 millimeter. Also, there is some questions about, is it suitable to do ablation more earlier than the option for surgical treatment? Because the ablation seemed to terminate the future risks with rather less cost than surgery. I think we still need more basic and clinical research data to answer such questions. we still got too much going on. That's all for my presentation. Thank you for your attention.
Thank you very much, Dr. Chen. I think that was, but we've seen a lot of cases on your presentation. I think that's very nice. And I'm sure we have some questions from our audience. So please wait till the Q&A session so that we can go ahead with the last speak. Thank you very much. Now we have Dr. Zhou with the topic of local effect and immune response of microwave ablation in the treatment of early breast cancer. Welcome, Dr. Zhou.
Hello, everyone. 那共享关一下，共享关一下。我共享不了。
陈主任，您共享退出一下，谢谢。
可以了吗？
可以了。
Hello everyone. Today my topic is microablation for early stage breast therapy and immune response. I'm from the first Asian hospital with Nanjing Medical University. I'm from the Department of Breast Surgery. So because of the great advance of screening techniques, more early stage breast cancer was diagnosed, so more chances for the minimal invasive therapies such as breast conserving surgery and sentinel lymph node biopsy. From this slide, we can show that from hardest radical mastectomy and the extent of breast surgery is very large, and because of the systemic therapy and our breast conserving surgery and sentinel lymph node biopsy becomes the standard surgery for early stage breast cancer. So conserving surgery is the therapy for early stage breast cancer, and it is widely used and reliable therapeutic effect and high and is accepted widely for all the patients and doctors. So, and the pathological evaluation of the margins is very important. So the improved appearance of breast cancer can be obtained after breast conserving surgery. So, however, the breast conserving surgery is a complicated procedure, and the wider local excision may induce more morbidities. So, according to previous studies, we can see that more than 20% patients are not satisfied with cosmetic outcomes after breast conserving surgery. So, is breast conserving surgery perfect? We can see the tumor lesion, the incision is left, and radiotherapy is needed for after breast conserving surgery, and repeated surgery is needed for some cases. So this is, I think, breast conservation is not perfect, but is accepted as a perfect treatment. For local therapy for early breast cancer therapy, from mastectomy to breast conserving surgery, is less injury, good cosmetic outcomes, and so on. So, further investigation of breast conserving surgery is also needed. For ablation of early stage breast cancer, we can see that we think ablation of breast cancer can obtain the same local control of breast conserving surgery, but the cosmetic outcome may be better than breast conserving surgery. So, because of the ablation of breast cancer can avoid the operation, and the previous studies suggest that the ablation is effective and safe. because of no resection of the tumor. Better cosmetic outcomes may be obtained for these techniques. We can see from this slide, we can see researches on ablation of breast cancer since 1996. And most of these researches are feasibility studies, and limited studies are focused on long-term outcomes of these techniques. From PubMed, we can see about 100 papers published every year for this technique of breast cancer. And the registered clinical trial was also about 100. So from this slide, we can see the research on from the feasibility studies. Okay, from this slide, we can see radiofrequency ablation and microwave ablation shows a high complete ablation rate because of the advances in cryoablation, and I think cryoablation also show very high complete ablation rate, and this is technicals with shorter ablation time. So I think radiofrequency ablation, microablation is a promising technique for the treatment of early stage breast cancer. Here we show you some limited studies focused on the long-term outcomes of ablation of breast cancer. This is from 3 patients, and the size was millimeters, ranging from 5 to 38 millimeters. The median about 1 year. See, these 3 cases, only 5 local recurrences was observed. We can show this case is a complete ablation rate, and 1 skin and 4 hematomas was observed from this clinical trial. So here another is very important study for radiofrequency ablation of early stage breast cancer. The enrolled criteria include aged over than 17 years, with the greatest diameters smaller than 3 centimeters, and the patients were refused surgery or unsuitable for surgery. And all these include patients who are luminal breast cancer, which is estrogen receptor positive patients. This is a very this slide we can show the complete ablation case, and the safety margin was very large. We can see here. Of these 21 patients, only 1 local regional recurrence was observed after 1 year of ablation. We can see this is maybe due to this technique cause. Only 3 local regional recurrence was observed after 1 to 5 years, and only 2 patients were diagnosed from breast surgery or breast cancer. So we conclude that radiofrequency ablation combined with neoadjuvant and adjuvant endocrine therapy was suitable for elderly breast cancer patients with small breast cancer. All these patients were refused standard surgery and central lymph node biopsy and radiotherapy. So for this patients, I can see the ablation was showed a very favorable long-term effect. We can see here published last year a very important prospective multi-center single-arm no-randomized clinical trial ICE3. In this clinical trial, from this clinical trial, we can see only enrolled 194 breast cancer patients aged from 55 to 94 years, and all these patients were underwent cryoablation. All these patients were with single lesion with the largest diameter smaller than 1.5 centimeters, and hormone receptor status was positive and HER2 negative breast cancer patients. With median 3 years follow-up, only 2% local recurrence was observed. So from this chart, we can see cryoablation of small breast cancer showed a very favorable local control. And we can see here another retrospective multicenter single-arm clinical trial from Japan. 386 breast cancer patients was enrolled. All these patients were with a single lesion with the largest diameter smaller than 3.5 centimeters, and followed up with a median of about 15 months. From all these patients, we can see the cases smaller than 2 centimeters. The local recurrence was observed 2% of all these patients. And however, when the diameter was larger than 2 centimeters, the local region was rate was about 10%. So the smaller breast cancer was radiofrequency ablation was effective for the treatment of smaller breast cancer. And this local recurrence was related to tumor size, lymph node metastasis, ER status, and radiotherapy. And then I will introduce microablation of breast cancer to our own experience. Compared with other ablation techniques, I think microablation was simply ablated, and they can ablation larger ablation zones and with shorter ablation durations. And our previous studies suggest that microablation was feasible for early stage breast cancer for the first time, and this data was published in radiology. Then microablation was in our center was used to treat early breast cancer in elderly patients with luminal breast cancer. From our data, we can see microablation of luminal breast cancer in elderly patients was safe and feasible, and the local recurrence rate was very low. From then, and we first find microablation of early breast cancer can induce NK cell responses in our clinical trial. Then we find microablation of early stage breast cancer can induce early activation of CD4 T cell responses for the first time, and this was published in JITC. And all the subgroup analysis found is that the activated CD4 T cell mainly induced by microablation patients with non-luminal breast cancer or include triple negative breast cancer and HER2 positive breast cancer. Then we use single cell RNA sequencing to determine the landscape of microablation induced immune response of early stage breast cancer, and we find the key mechanisms of this microablation induced immune response. And we first find B cell combined with CD4 T cell was very important pathways for this immune response. And then in vitro, we find immune checkpoint blockade can activate the CD8 positive T cells further. So we can see microablation may be combined with immunotherapy was a promising treatment strategy for the treatment of breast cancer. In summary, we think ablation of early stage cancer was very high complete ablation rate. We can say I think is larger than 19%, and with fewer complications and better cosmetic effect. But ablation of early stage breast cancer has not been widely used. The limitation of ablation therapy for early stage breast cancer, we can say most researchers published are focused on the feasibility studies, and incomplete ablation rate was about 10%. But in surgery, the margin in pathological, and this 10% was not acceptable for surgery for surgeons. And the number of include all the studies in most research is limited. So, and few researchers are focused on long-term outcomes of these patients. So we compare local ablation with breast conserving surgery. For ablation, no pathological evaluation of the margin is very important. For breast conserving surgery, the margin, the pathological margin is reliable for the surgeon to take this surgery. And incomplete ablation might delay the treatment of breast cancer. So surgeons, I think surgeons are very, include me, like surgery very much. Breast conserving surgery compared with plastic surgery can in large extent of the resection. So we think, but few incomplete ablation can be found by imaging examinations, I think. So both ablation and breast conserving surgery can omit the low-grade DCS component. For breast conserving surgery, radiotherapy is needed, and we think ablation of breast cancer, combined with radiotherapy is very important. For ablation of breast cancer, we can see, I think, a better appearance of breast with surgery is better cosmetic outcome can be obtained for these techniques. So ablation is unperfected, but has many advantages and for the treatment. So I think precise ablation is needed instead of in refusing ablation. We can include suitable patients for ablation of breast cancer, such as localized invasive breast cancer. And these cases with extensive introductor component can be included for the treatment of ablation. For the precise ablation, you can say suitable ablation techniques was used, and after ablation, the imaging evaluation was very important for follow up. In the future, I think ablation with systemic therapy were very important, such as immunotherapy, chemotherapy, and so on. So we think ablation therapy has a good prospect in breast cancer, and more long-term research are needed. Dimitris is needed for this treatment, and more support and promotion are needed for this technique. For the local treatment of breast cancer, we can see from the minimal invasive to non-invasive. And that's all. Thank you.
Thank you very much, Dr. Zhou. That was a very good presentation. Thank you very much.